recording. So we're recording onto the cloud. And then for the people who are joining from other provinces and they are right in the middle of doing their dinner or whatever it is that they can't join today, they can still take advantage by watching the replay. Okay. So this is Amanda, everyone. She is a nurse practitioner, and I'll let her explain a little bit more about what she does. But we're going to have an open discussion today, and we have our little chat open so you guys can ask questions, and Amanda's happy to answer. I'm just going to say hello to everyone so that you know that I'm here, and this should also kind of pop up for you so you can see where the chat is, and then you can ask questions. And we're just going to start with a little bit. So I wanted to just out of curiosity, I'm just wondering, can you tell me why you decided to go into nursing?
Oh, originally it was because I figured I would end up going to medical school and I would be able to work summers before. And then I ended up down in the States and I saw this fantastic mid-level care provider option that had a great work-life balance and really had a lot of autonomy in their own practice. I've done women's health nursing since I graduated in 2005 as a nurse practitioner. And I've done everything from sexual health services and reproductive health services, working with pelvic floor dysfunction, lots and lots of labor and delivery as well. And what I ended up settling on and specializing in is midlife women's care, because there's lots of people that are doing a good job of contraception, lots of care providers that are doing a good job of obstetrics and gynecology. And unfortunately, midlife women are just falling through the cracks. So I sought out and was certified as a certified menopause practitioner through the North American Menopause Society in 2017. And the rest is history. I've been looking after midlife women almost exclusively since that point in my career.
Yeah, and I bet it's pretty busy, right? Like, do you have a long wait list to get in? And
yeah, I think right now, if you're looking to see me, it's probably late January. So a while anyways.
Yeah. And then you're in Regina, is that right?
Yes. Yep.
Yeah. Just so you know, anybody out there, joining the meeting or listening, and you're okay if people send messages and ask you questions after.
Well, I don't really, I couldn't possibly keep up with that volume. If people are interested in a consult, I'm hoping I'm going to answer all the general questions, and then it really is very individualized. We're going to talk a lot about how important it is. Every woman is her own unique experience, her own unique ecosystem. When we're talking about hormones or not, there's very individual factors. So it's really challenging sometimes for me to answer very specific questions about patients when I don't have the whole clinical picture. If I'm not your care provider, I don't have access to your labs and all of the things that we need to factor in when we're having a very comprehensive, individualized discussion about risks and benefits related to hormone therapy or any other care.
Yeah, and I totally understand what you're saying, because I've been diagnosed with endometriosis later in life. This was not a problem for me before that we were aware of, but it does change how I can be treated at this point. So that's very important, right? I can't just take like the general, rule and say, oh, I could probably use an estrogen therapy, because that's off the table for me.
Yeah, and there's a host of complications that all of us have as we age that are very individual. So every woman's journey is definitely very different. As we're getting going here also, I just want to say that I'm just kind of going to give an overview of perimenopause and menopause, but every woman's journey is unique. It's really important that you find a care provider that you align with, that's able to support you on this journey. It's also today, just in the interest of time, I'm speaking generally, so I'm not specifically speaking to any specialized patient populations. So for trans men and trans women, it's a different discussion when we're talking about gender affirming menopause or gender affirming hormone therapy than just general systemic menopause hormone therapy or local menopause hormone therapy. So I don't mean to be exclusive of anyone, but just in the interest of time today, I'm just kind of talking globally about the perimenopause and menopause journey. Also today, as we're talking, behavioral and lifestyle pieces are so very important, and they definitely can't be disregarded. My approach to menopause and perimenopausal journey is very much that we have a big puzzle, and the more pieces of the puzzle you get into place, the healthier and happier you're going to be with both your mental health and your physical well-being. I always tell women, I'm like, I prescribe lots and lots of hormones, but I certainly never, ever lay claim to the fact that there's a magic wand. It's usually a piece of the puzzle to getting you feeling your healthiest and best self. So as part of that, some of our discussion today might include nutrition and exercise. A huge piece of the complaints that I hear in my clinical practice definitely surround not only the symptom of weight gain, especially the middle weight gain at this stage of life, but also kind of our long-term health risks that go along with that. So an increased risk of cardiovascular events, an increased risk of stroke, an increased risk of type 2 diabetes, and eventually potential cognitive decline. So I always just like to, at the start of a conversation, make sure that women are aware that we will talk about nutrition and exercise in the context of the changes that happen to us at middle age, in the context of health. But occasionally, if people have suffered from disordered eating in the past, that can be triggering. So I just don't want it to be a surprise that is probably going to be part of our conversation today, because some of those factors do change and definitely weigh into how we're feeling our best or feeling our very worst. So I just like to make sure that people are aware that that will be part of the conversation today as well. As Jessica has highlighted here, we've got the group chat on the side, and I welcome you to weigh in with your questions as we go through. If we're touching base about something and you're like, oh, I need more clarification about X, Y, or Z, please feel free to type in, because guaranteed, as much as we're all unique, there's definitely some commonality to this path that we're all on. So it's one of those things that go ahead and weigh in, and I will try and keep my eye on the chat here as well and incorporate and answer those questions as we go through. Okay.
That's perfect.
So
And
when
just one other thing I wanted to say, and this has come up just in this planning of this symposium, is that, and I noticed this right away, there's a flaw in kind of how we talk about menopause, and it comes with this misconception that menopause is when your period stops. And then that leaves out everything that happens before, when you might have, irregular periods and some of the weird symptoms that we talk about in the group all the time. And that's why I called it perimenopause, menopause support, not to leave anybody out. But then the gals who were postmenopause, even one of my really close girlfriends today just sent me a message and said, don't forget about postmenopause. So I'm wondering, we're just going to make sure that, we're including everybody here on this journey, right? Whether you haven't had a period in 12 years, if you're having symptoms, then this is for you.
Yes, for sure. Because those are all very different clinical situations. So when we actually look at some definitions, because sometimes it's helpful to have that. So the perimenopausal journey lasts anywhere from about 4 to 11 years for most women. And it tends to be the most difficult from a symptom perspective for the majority of the population that's suffering. So that perimenopausal transition is all of a sudden we don't have our nice, beautiful ebb and flow that's predictable of our ovarian sex hormones. So there's not the predictable surge of FSH and LH and estrogen and progesterone each month. It's kind of more of a chaotic, erratic ovarian function. So some months we're missing actually releasing an egg. Some months we're having a period in the absence of ovulation, and we have lots of disruption in what those normal hormones are. So things are no longer predictable. All the rules are kind of out the window. So most often in this perimenopausal transition, we start to see symptoms such as changes to your menstrual cycle. So some women are going longer, some women are going shorter between their cycles, some women are having heavier flow with lots of clots, some women are having barely any menstrual flow or kind of scant bleeding. Some women can go months and months and months between periods, but things are just generally more unpredictable. Hot flashes often become problematic at this stage. Night sweats become problematic. Lots of mood changes is what I see in my practice. So lots of emotional lability, lots more emerging anxiety, lots more depressive symptoms. This is often even more prevalent if it's a risk factor for more of the depressive symptoms if women also struggled with postpartum depression. So that's sometimes like a red flag that we can see more of that. Lots and lots of sleep problems, everything from difficulties with sleep acquisition. So we go to bed and we can't can't fall asleep to, we fall asleep exhausted at night, but then we're wide awake at 2, 3, 4 o'clock in the morning and our brain races and we can't fall back to sleep. Lots and lots of weight changes, in particular, kind of a redistribution of our weight. So lots and lots of middle weight gain and what we call that visceral fat or abdominal adiposity, which really increases kind of systemic inflammation in our body, which gives us lots more musculoskeletal complaints. So lots more achy joints, things just hurt. It takes us a while to roll out of bed in the morning and get going because things are just not as comfortable and it's a real challenge. I see some women with heart palpitations, certainly more emerging anxiety, lots and lots of brain fog, and definitely low libido and vaginal dryness. So those are kind of the laundry list of symptoms that I see primarily in that perimenopausal transition. So menopause is officially defined when it's been a full year since our last period. So from a natural menopause perspective. So we certainly can have surgical menopause where you've had your ovaries removed, or we can have medical menopause. So sometimes, especially cancer treatments or certain treatments for endometriosis, those things completely shut down our ovarian function. So we can have surgical or medical menopause, but natural menopause is officially when it's been a full year since that last menstrual period. And I should just note at this point too, if it's been a full year since your last menstrual period, it's really important that you see someone if you have any bleeding at that point, because it's not normal at that point for our periods to come back, and you should be evaluated with a pelvic ultrasound and an endometrial biopsy just to make sure that there's no abnormal cells there or anything of concern. Okay, so those are kind of our big transitions. Post-menopause, so we officially know we're menopausal once it's been a full year since that period, that last period, and that's when you're considered to be post-menopausal. So I always tell women, I'm like, we're either kind of perimenopausal or we're menopausal, but we don't know until we've been menopausal for a year, essentially, that was our last period. So it's really helpful at this stage, if you're in the perimenopausal transition, to get an app on your phone or find some way to actually track and keep track of your cycles, so you know. Because honestly, from a medical perspective, if it's been 8 or 9 or 10 months since you had your last period, we're like, you were so close, you almost crossed the finish line, versus our reaction being like, that's postmenopausal bleeding, we need to get this evaluated properly. So just for your own health and safety, it's important you kind of keep track so you know when that last period is and kind of what's happening for you at this point in time. When we look at where we're at for treatment of just from the medical perspective, in the 90s, essentially, they thought hormone therapy was going to be the fountain of youth. And so primarily there was oral conjugated equine estrogen. So that's not biochemically identical to any estrogen that our own bodies produce. It's derived from pregnant horse pee. And they did a big study with that orally and then a synthetic, so again, not biochemically identical to anything our own bodies produce, progestin, in a very large number of women globally. So this huge study in the late 90s was called the Women's Health Initiative. And as I said, at that point in time, what we anticipated at the start of that study was that we were going to essentially tap the fountain of youth for women. So they thought at that point that women would live longer, they would have better cardiovascular outcomes, they would have less breast cancer, certainly less osteoporosis, better brain function as we aged. So they undertook this very large study. The women in this study, so it's very important, and this still holds true to this day, if you're doing enough estrogen or to treat your whole body and you have a uterus intact, we also have to give you progesterone, because essentially estrogen functions in the uterus like when you fertilize your grass. So it really stimulates that lining of the uterus to grow. And then progesterone essentially is like cutting the grass. So we don't want the lining of that uterus to grow unchecked, because it can lead to some precancerous or cancerous changes in the uterus. So if you have a uterus, and still this holds true to this day, you also need to have progesterone if we're giving you enough estrogen to treat your whole body. Mm-hmm. So for those women that had a uterus, they received both estrogen and progesterone, and women that did not have a uterus received just estrogen. Well, 3 years shy of when the study was supposed to complete, they pulled the plug on it. So in 2002, globally, they hit the panic alarm because they were seeing far more incidences of breast cancer. They were seeing far more instances of heart attack and stroke. And essentially they were in a panic. At that point in time, they pulled all of these women off. And it's really most important to note that those women were of varying ages. There were lots and lots and varying amounts of time from their menopausal transition. So these were not just women that were within 10 years from that final menstrual period. There was women that were well beyond that in their 60s, 70s, and 80s. So we got bad outcomes. They globally hit the alarm button. And essentially we moved into this place for a good decade where everyone was terrified of hormone therapy in general. And so that's where you still see a lot of hang up and lag with some clinicians to this day, is there's very bad taste in people's mouths. People are very fearful of hormone therapy because at that point in time, essentially nobody globally had access to it. It was, this is bad, we're going to kill women, we need to not offer them hormone therapy. This is just something natural that they need to go through, a stage of life. And my thoughts on that, because that's a myth that I hear a lot of, is women say, oh, my doctor won't prescribe because they say this is just natural. This is what's meant to happen. And I say, until the last century, what was natural is that we'd have 15 to 20 pregnancies and we'd hit menopause and drop dead within a year, right? We never ever used to have the medical advancements or nutrition available to us where we would actually live a third to a half of our life beyond menopause. So I really don't ever want you to settle and accept that as an answer, that it's just natural, because we're in a completely different circumstance than that. So we had this good decade where no one was prescribing any hormone therapy. And at that point in time, that's when it really became popular to talk about compounded hormone therapy or bioidentical hormone therapy. And so bioidentical hormone therapy, there's a lot of different definitions that float out there. And for myself in my clinical practice, that looks like any hormone therapy that is biochemically identical to hormones our own body produces. So whether that looks like a micronized progesterone that's biochemically identical to the progesterone our own body produces, or whether that's an estrone, which is biochemically identical to the E1, estradiol, which is biochemically identical to the E2, or estriol, which is biochemically identical to the E3. Those are all biochemically identical. What is different, and I like to differentiate between, is that biochemically identical hormones or bioidentical hormones don't have to be compounded. And I think it's an important distinction to make because we have lots of commercially available biochemically identical hormone products. And I say that, and those are really what by and large is supported by the North American Menopause Society, which is now known as the Menopause Society, and the Society of Obstetricians and Gynecologists of Canada, as well as the American College of Obstetricians and Gynecologists. And the reason that they support those that are commercially available is because there's a lot of checks and balances in place. So when products do come from a commercially available factory, they have to undergo batch and quality and lot control testing every 24 hours. They are legally mandated to include a warning label in all of the products. So there's a lot of quality control that's available there. Oftentimes what I see is patients who want bioidentical hormones, and they want to, do salivary testing and have something compounded that's exactly this percent and exactly this percent and exactly this percent for them. And certainly that's available. It's not endorsed or encouraged by our big governing bodies and prescriptive practices, simply because we have commercially available biochemically identical products, which your insurance is also much more likely to cover. So I always like to mention that because most of the formulary plans will cover those. I certainly do some work with compounded hormones when I don't have the option for a commercially available product. So by and large, because I have a fantastic progesterone available, I have fantastic estrogens available, whether we're talking about systemically or locally, which I'll talk about further. But sometimes when we look at DHEA, that's something that'll have to have compounded because we don't have a commercially available product in Canada. Or occasionally when I'm looking at prescribing testosterone, I have that compounded because we also don't have prescriptions available for that for women in Canada as well. So those are kind of those two exceptions to my own prescriptive practice, but you'll see a whole spectrum of things in clinical practices out there. Every provider kind of has their own their own thoughts and their own approaches. And I'm certainly not discounting anyone else's, but that's kind of the history of why we came to a place of having compounded biochemically identical hormones, because we couldn't get anything commercially available, and women continued to suffer and demand care. So I think that was kind of the era of Oprah and Suzanne Summers being very vocal about, you must get relief, and these kind of saved our bacon, essentially. But we have other options now. So there's definitely lots of options that are commercially available, biochemically identical, without having to go through a compounding pharmacist. So most of your prescription drug coverage will cover at least some portion of those products. Do you have anything to add for that, Jessica? I know that is a mouthful.
Yeah, it's a lot, and it's a lot to learn. I've had people in my group be like, oh, so you're pro HRT. And my own personal take on it is each individual woman, because we have a somewhat different circumstance, it's hard to have this attitude of yay or nay. I kind of don't do that in general in my life and in my world of there's whatever. I think they did a test one time. They were trying to see like who's right about how to do the dishes. So they actually did a scientific survey. How many different ways are there to do the dishes? And there's like 150 different ways to do the dishes. And there is no one right, correct way of doing the dishes. So I often just kind of say, I think that the right form of treatment is what's going to work for that woman. Exactly. And her lifestyle. So say she has a really firm idea in mind that she needs compounded bioidentical for her, then she should find that somewhere, if that's really important, because we have that heightened level of anxiety. We need to be really comfortable and feel confident about what we're taking, and have a practitioner that we feel has our best interest at heart. And I think that's where some of the disappointment comes in, where, it doesn't seem like the doctor's listening to us, or they just kind of dismiss us. And I was wondering if you talk a little bit about specifically using antidepressants, because we hear that a lot in the group, where I think it's an attachment to like a negative stigma of not wanting to need that help, or we shouldn't have to have that, or if we take it, we're going to get stuck on it for the rest of our lives. And my family doctor said, for those of us in this perimenopausal stage, usually that's not the case. You'll take it for a number of period time, however long it takes you to get through the transition. And then usually when you're on the other side of it, you don't need it anymore. So I was wondering if you could talk a little bit about using antidepressants and why that seems to be like the go-to when someone presents with perimenopausal symptoms.
Yeah. And so we know that antidepressants certainly can help with the anxiety piece. And oftentimes, if we can kind of sort of help the anxiety piece, it certainly helps with the hot flashes. About 50% fewer hot flashes in a 24-hour period with a low dose antidepressant. So it's significant improvement in hot flashes and significant improvement for most women in anxiety and depressive symptoms. So if that is just what they're presenting with, then that can make a big difference for them. So it really depends. When I see women that are having hot flashes, but are also having lots of sleep disruption and lots of vaginal dryness and all of those kinds of things, the antidepressants certainly don't address all of those things. The other piece that's important to note is everybody's risk factors are different. So some women are maybe not comfortable with the risks that go along with a low dose hormone therapy. Some women are more comfortable with the thought of a low dose antidepressant. And typically, if I'm prescribing for hot flashes, it is usually a lower dose than I would start somebody at if they were presenting specifically for depression. So we can usually get results with hot flashes at a lower dose than we even need to start with the, sorry, I'm just distracted by the chat here.
There's a little question there about intrarosa. I'm not sure what that is.
And I'm not sure, Erica, it's honestly probably been 6 to 12 months since I've checked on the intrarosa, because we did have it not available for a long time in Canada. So technically it was supposed to be available. And then I think there was some issues with the production company. Yeah, so if it's back up and running, then it's great if it's available again, because I think it was coming out of somewhere around Montreal and it wasn't available for a long period of time. So there was a major supply chain issue with the intrarosa. So I've been having to do it with compounded DHEA. Yeah, so that's perfect. So with the antidepressants, it's really an individual approach for each woman, but the antidepressants definitely at a low dose can help improve the anxiety, depressive symptoms, as well as hot flashes. Many women also improve from a mental health perspective. We have more estrogen receptors in our brain than almost anywhere else. So for anxiety and depression, there also tends to be a big benefit. So if we're treating for hot flashes, most women find that their anxious and depressive symptoms do improve as well. I'm not saying one is superior over the other. It really is a unique woman to woman discussion, but from the mental health piece, there's benefit to both of those for both anxiety and depressive symptoms as well as hot flashes. I see a
That
lot
too. I've
of
seen that too. Like I have one client who was really like did not want to broach the antidepressant side of things at all because of negative experiences in her 20s. But she was not functional, like not able to work, not able to sleep, lots of hot flashes, really couldn't cope with anything. And so she did decide to try one of the ones that's specifically good for the hot flashes, Effexor, I think it is.
Mhm.
And then that also helped her a lot with just the generalized anxiety disorder. And she started to feel a little bit more hopeful and, going out a little bit more and, getting her groceries and a little more chatty, a little more time with her socializing and with her friends. And then the next step was addressing the sleep. And she was put on a different kind of antidepressant that actually is really good for sleep and started sleeping again. And then went and got a nice government job and is working towards getting her pension and helping at Parliament every day within like a year and a half.
Yeah, it really is just advocating for yourself and not allowing someone to say to you, oh, it'll just pass, or it's just a fleeting stage, right? And it honestly, everybody has their area of expertise. And honestly, healthcare is no different. Not everyone's going to be an expert in every single thing. A lot of that is often driven by what people are passionate about. And I think about it, I exclusively do women's healthcare, and the volume of continuing education that's involved in that is onerous some days. So I can't even imagine having a clinical practice where you were expected to be the expert on absolutely every patient population at every age for every single health condition. That would be overwhelming. So I give them a huge amount of credit, but I always tell women, I'm like, if you're not getting the answers there, don't stop. So I love the North American Menopause Society, which has just recently this year rebranded themselves as the Menopause Society. And if you actually Google their website, they have find a menopause practitioner near me. So you put in your postal code and it will pull up people that have this special certification and training and designation as a NAMS certified menopause practitioner. So if you're really struggling and you're not getting the answers that you want from your care provider now, there's always the option. Some of the bigger centers have fantastic midlife women's clinics. So that's something that you can always Google. I think there's a huge amount of benefit, no matter what we're talking about, to having a team of people look after you, right? I love a good naturopathic physician, not an exclusion of everything else, but as a part of your team. It's just really important. And I think you and I spoke before, there's so much information out there for women. There's really an upsurgence and women are just really advocating for themselves and want to know more information. Like there's fantastic podcasts out there and YouTube channels and everything else dedicated to educating and informing women, so that they can get the information that they need to really have an idea about what they want and which direction they want to go, for sure. So it's very important. And so when we're looking at hormone therapy, I think it's really important to differentiate between systemic hormone therapy, so enough hormone therapy to elicit a response in our whole body. So whether that's, treating hot flashes or any of the other symptoms that we talked about, or for women who are intolerant of osteoporosis meds, there's that. And like I said before, it's really important, if you do go on enough estrogen to treat your whole body, that if you still have a uterus, that you're prescribed a progesterone, because at least on a weekly basis, I will see women that have postmenopausal bleeding, and it's because they've been prescribed somewhere unopposed estrogen therapy. So if you have a uterus and someone gives you enough estrogen to treat your whole body, we also need to give you a progesterone component or a progestin. If you are just treating the tissues of the bottom, so this is another big myth that I see. So when we're looking at just treating genitourinary syndrome of menopause, which used to be previously referred to as vaginal atrophy, what we see is the tissue of the vagina and the vulva, so the external genitals, becomes very thin and dry and fragile. And this comes for all of us at different times. So for some women, they experience this very early in perimenopause, so long before they're done with their periods. And oftentimes I see that they've been told, well, it can't possibly be that. You're still cycling. Like, we can't treat you. You're still getting your periods. And that's not true at all. This can come, and it's with the declining estrogen levels. This tends to be progressive. So the longer we are with less or no estrogen, what ends up happening is that tissue just becomes thinner and drier and more fragile. So we have a real loss of the elastic and collagen fibers. We lose the robust nature of that tissue. So essentially the vagina goes from being a pleated skirt with pliability and give, right? We're built to pass new humans. So with that tissue supposed to be nice and pliable and robust, to almost having a pencil skirt. So there's really not that pliability and give of the tissue anymore. What we don't see is that there's a loss of the good bacteria in the vagina. So we lose the good bacteria called the lactobacilli. And what the lactobacilli do is they create a byproduct called lactic acid. And that makes the vagina actually a very acidic environment, so that when we have enough estrogen, that acidic barrier is really very protective against the bacteria that we all have in the backside. Honestly, it's not a hygiene issue. It's not about how much you shower or how well you wipe. There's bacteria back there. And when we have that acidic barrier in the vagina, the bacteria from the backside has a very difficult time trekking its way up and getting into the bladder and causing an infection. So with the genital urinary syndrome of menopause, I see lots of women have issues with vaginal dryness. Lots of women have painful intimacy. Lots of women have a loss of pleasure with intimacy. Lots of women start to get more bladder infections. Lots of women see me and they just say, you know what, Amanda, I've been tested and I just feel like kind of irritated. Like, I honestly, there's many days where I feel like I'm getting a bladder infection, or there's many days where I feel like I'm getting a vaginal infection. Things just don't feel right. But they've tested me and I don't have an infection. What's going on? And it really is the loss of the good bacteria in the vagina, and it's the loss of those elastic and collagen fibers. So the good news is that a very low dose option of local vaginal estrogen therapy, you do not need to have progesterone just with local vaginal estrogen to protect that uterus, because it's such a low dose that it really acts locally. So it addresses kind of the tissues of the vagina, the vulva, and to some extent the bladder. So I see lots of women have fewer bladder infections, up to 50% less in a year with their treating the tissue. Intimacy becomes much more comfortable. The tissue in general becomes much more comfortable. And I also see about 50% of women improve with symptoms of urgency and urge incontinence, which can often kind of emerge at this stage of life. And so urgency incontinence is the type of leakage where you almost get an overactive bladder. So it feels like you have to go pee a whole lot more, but it's not an infection. You feel like, I got to pee, and then you're leaking on the way to the bathroom. Certain triggers tend to do that. If you get home and put your key in the door, and you're leaking with that, that's an overactive bladder. Here, running water, going to get in the shower, those kinds of things. So that tends to improve in about 50% of women when we treat that thin, fragile, dry tissue. So it's really important distinction to make that you don't need progesterone with that. It is such a low dose that it really acts on those tissues alone and is not enough to impact the rest of your body, so that it's not actually enough to increase the risk factors for those things that we're concerned about with systemic therapy, which we're going to talk about in greater detail in a moment here. So local vaginal estrogen works very well in certain patients. So there's three basic options available that are commercially available. There's actually four. I tell a lie. In Canada anyways. I'm not sure if we have Americans on with us right now,
No,
but
Canadians.
So I don't really prescribe Premarin cream anymore. It's pretty old school. It's the original conjugated equine estrogen. It's what has formulary coverage, at least in Saskatchewan, which means that it's the cheapest, and people tend to get veered that direction. I'm not a giant fan. It doesn't have a nice viscosity. It's very heavily fragranced. It's again conjugated equine estrogen. It's derived from pregnant horse pee, and it's heavily fragranced to cover up the scent of that. It smells very heavily like roses. And most women, I see more women have irritation from that than any of the other products. So I'm not a big fan of the Premarin cream. I typically prescribe, from a cream perspective, a lot of Estrogyne, which is an estrone product or E1 estrogen product. And that's just typically used intravaginally a couple times a week. And you don't need very much. Or there's Vagifem tablets, and those are preloaded applicators that are inserted into the vagina at bedtime. I have to laugh. There's in the many years of clinical practice, it's always the things that I learned the hard way. I had one woman say to me, she's like, it just seems so wasteful. She's like, everyone has an applicator. And she goes, and I just go like this. And it was like a Pez dispenser. So those go in the vagina. They are not taken orally. There's no benefit to your whole body. They work very well. That is the lowest dose product. Typically, if women don't have any other contraindications to slightly higher doses of estrogen, that one I usually use 2 weeks in a row, and then just go down to twice weekly dosing. And then there's a ring called the S-ring that goes into the vagina that stays in there for 12 weeks. And it delivers a small amount of a 17B estradiol, so the E2 type of estrogen, to the tissues. That's particularly helpful for women if they have a lot of mobility issues, or as we progress in years, if they have a lot of arthritis or those sorts of things that make it very difficult for them to navigate an applicator a couple times a week. That can be something that's helpful as well. So those all have those benefits, and it looks like, thank you for that information. So if the Intrarosa is available again in Canada, the DHEA is kind of a precursor that our body can make either estrogen or testosterone out of. So the DHEA in the vagina, we only have estrogen receptors, but on the vulva, so kind of like the periclitoral area, extending down the labia and around the vaginal opening, we have both estrogen and testosterone receptors. And so when we use the Intrarosa or a compounded DHEA product, we're stimulating both of those receptors. So it not only helps to plump up the tissue, but the thought is some women find that they have a little bit more stimulation of those testosterone receptors externally. So they may have a little bit more sexual satisfaction with that. Again, no magic wand for any of this. I think it's important to be clear with that, but that's kind of the school of thought about why we would prescribe DHEA over an estrogen only product. So
that sounds good. I'm actually on DHEA and I've been on it for a few years, but that's from a functional medicine doctor who she's really very alternative, and I was really lucky to find her. And it does make a big difference. So it's something that is definitely helpful if you can get someone to prescribe it, which I guess is the challenge that a lot of women are facing. My family doctor is excellent, but she just said, I don't feel competent and prepared to deal with prescribing hormones. So if you've got someone else to do that, perfect.
Yes. Yeah. And so in Alberta, is your natural, like your functional medicine, your naturopath able to prescribe hormones? I know in Saskatchewan, naturopaths can do the testing, like with the Dutch testing and that sort of thing, but they can't actually prescribe in Saskatchewan.
Well, she's a medical doctor, so she went through and did her like family doctor thing, and she was in a practice doing family medicine, but her story was kind of like her husband started to show early heart disease. And so they started really looking into alternative medicine together because he was also a doctor. And it kind of informed their whole practice. And they moved towards more of this functional medicine of looking at the whole system to try to figure out what exactly each individual person needs. And then that led her into prescribing hormones because sometimes that's what that individual person needed.
Yes. Yeah. And I love that approach, right? It's one of those things that often we fall shy in Western medicine of looking very much at just writing a prescription or living with the illusion that there is a magic wand. And by and large, what is going to help people feel the best is a whole bunch of pieces of the puzzle, of which hormones is sometimes a piece of, but not the whole story, right?
Mm-hmm.
So when we look at systemic hormone therapy, there is a whole plethora of different brands and types that are commercially available. When we look at what's available, estrogen therapy by mouth is the most risky, because when we take estrogen by mouth, our liver has to process it, and it undergoes something called the first pass effect. And because our liver also processes all of our clotting pathways, we do see an increased risk of blood clots, whether that's a blood clot in the legs, in the lungs, causing a heart attack or a stroke. So there is an increased risk for clotting when we take oral estrogen. Most people that are a low risk patient for a blood clot to begin with, so they are basically healthy, they're not a smoker, they've not got any history of that, no strong family history of that, have beautiful, lipid profiles, not diabetic, not a smoker, not a big drinker, all of those kinds of things. Most people are just a fine candidate to use oral estrogens, but we know that it's much safer to use estrogen through the skin. So transdermal application of estrogen, and that's available in lots of different commercially available products in either gels or patches that we swap out typically twice a week. If you do have a uterus, I'm a big fan of micronized progesterone. Your progesterone, you always want to take at bedtime. So when we take progesterone is very sedating. So I will sometimes see women say, I feel so much better for my hot flashes. Somebody put me on estrogen and progesterone, but my energy levels are just terrible, right? Like I feel like my hot flashes are better. So I'm actually sleeping a little bit better, but like I can barely drag myself out of bed. And so it's one of those things that sometimes is as simple as they were taking their progesterone in the morning. So progesterone we need for that endometrial protection. But progesterone, as long as we're not taking too much of it, is kind of lovely from a calm, relaxation, sleep well place. So I usually tell people take this about an hour before bed. So and that again is commercially available, a micronized progesterone, biochemically identical to what our own body produces. The amount of estrogen that you're taking really is going to drive how much progesterone you need. So the threshold for where we need to increase the progesterone it changes. So we can make sure that we're, as much as we're fertilizing, we're cutting the grass essentially. So we don't end up with that endometrial overgrowth with that. Do I have an update about the estradiol shortage? To the best of my knowledge, I've had a phone call from the pharmacy last week about asking for a different prescription for a patient. So I don't know what's going on. I just know when I write things and they send me back a message that they're not supplying them currently. So estradiol has been out of supply for a while. The 0.5 milligram dose, the patch was around. It was just kind of missing the 1.0 and the 0.25 milligram doses. So I'm not sure where the shortage is at. I apologize. I don't have exact details about that. Your pharmacy, if you phone, they'll let you know where things are at. Just in response to the chat here. I get a lot of questions about women, whether or not they need to test. So I see a lot of women and they're always like, no, I heard on the internet, I need to test, Amanda. And the sad news of what we have available to us, with at least in Sask Health, I'm assuming it's kind of Canada wide. If I send someone off with a requisition to the lab to test for hormones, it doesn't tell me a whole lot. It lets me know if you're menopausal or not. And I know that by whether or not you've had that last period. The problem with our labs when we test with blood work is that it's very black and white. And there's a huge wide range of normal. So during your perimenopausal transition, if you're still cycling, you're going to be somewhere in that range of normal. Except we have no idea if you were up here previously and you fell down to here. The important part to me is, what are you feeling? It really is important. You really want to have somebody that's going to sit down and sort through your individual symptoms with you and figure that out. That's much more meaningful during this perimenopausal stage than what we have available to send for blood work. Honestly, I don't send anybody for blood work just through our labs here unless they're infertility patients or unless they are 30 years old and they're not pregnant and all of a sudden their periods completely disappeared, because our wide range of normal and our hormone levels fluctuate so dramatically. I could test you 12 hours later and probably get dramatically different answers that would still be within the normal range somewhere. So that's why I typically don't test with what we have available here. Most patients, when we sit down, you have to be patient with hormones, right? Everybody's different, and there's not a crystal ball that we can look in and say this patient needs exactly this. It doesn't work exactly like that. And people are different levels of sensitivity to hormones. There's other things besides just the sex hormones going on. Certainly, we have cortisol, which is our stress hormone. We have insulin resistance, which starts to become problematic at this stage of life. and those blood sugar instabilities play a huge role in what's going on with how we feel. So there's not one tried, tested, and true way. That's why it really is important to find somebody to work with you. I always tell patients it's really important to be patient, though, because honestly, anytime we start hormones or switch hormones, inevitably I have patients a week later that are calling the office and saying, you need to tell Amanda that I have a headache, or you need to tell Amanda that my breasts are tender. And I always say, you need to revisit our initial conversation where we talked about the fact that it's going to take your body 3 months to get used to this, because it really does take a period of time to kind of sort of calibrate and figure out where you're going to settle and how much better you're going to feel and where we need to go from there. Otherwise, we just end up chasing our tails. So we're just constantly increasing or decreasing doses, and we never know where it's going to settle. So it really is just kind of a patience and persistence philosophy when we're looking at dealing with things like hormones. Our approach for hormones generally should be, in my humble opinion, to start low and increase accordingly to the point where we get relief. Hormones are no different than anything. You can have too much of a good thing. So it's not just, I see lots of patients and they're like, well, just increase my dose, just increase my dose. I want my energy to be better. I want this, I want this, just keep increasing. And it doesn't really work like that. It's as soon as we increase the dose, we do increase the risk, and the primary risk, though less so when we use the estrogen through the skin, would be thromboembolism. So again, a clot in the legs, the lungs, a stroke, or heart attack. That's very rare in a healthy population. And that's why you need to have somebody who really helps you navigate this. The safest time to start hormone therapy really is within 10 years of that last menstrual period. We know that after it's been more than 10 years without our own estrogen, we really start to see what's called endothelial plaques start to build up. So we have a lot more of the buildups in our arteries. And so what ends up happening is when we start estrogen, it becomes a very difficult situation where we're much more likely to throw a clot. So that's why the safest time to start hormone therapy really is when you're having symptoms, right? I always feel bad when people have suffered and been told, there's nothing that we can do for you, or you just have to tough it out. And then I see them and they're 20 years past their menopausal transition. And it's a very difficult conversation because it is definitely much more risky to start hormones at that point in time. So because we have more underlying health issues and more risk of heart attack or stroke, essentially.
We've got a couple questions in the chat, so I just want to make sure they don't get lost. And this one is at 37, wondering about how to convince a gynecologist or doctor that they are in perimenopause. So I would assume that means they're presenting with those symptoms, but maybe they're still menstruating regularly. This happened to me where I was still having regular cycles. And so I was told, well, there's no way that could be perimenopause because your cycles are perfect. They're happening exactly when you would expect.
Yeah.
So what do you say about that?
And so it's also, I have to go back to, which is unfortunately an hour is just not enough time to kind of sort of cover everything, but the behavioral and lifestyle pieces are huge. What ends up happening is we head towards middle age is we all become somewhat insulin resistant. And when we are insulin resistant, it's very easy for us to get on the blood sugar roller coaster. When we're on the blood sugar roller coaster, so kind of this spike of our blood sugar and then a dramatic drop, we're full of systemic inflammation. And those symptoms look very much like perimenopausal symptoms as well. So it's very confusing because honestly, we're on this blood sugar roller coaster just naturally, just because we're lucky enough to get older. And then we're also having some chaos with our ovaries and having some sex hormone. But like I said, I don't ever think that it's just a magic wand. Really, just Cliff's Notes version, when we look at stabilizing those blood sugars, many women feel much better. And I'm not discounting at 37 that you're perimenopausal. Absolutely. I see it all the time. But I always, for all of us, from symptom management now, but also long-term, it's really important to think about putting in less artificial sweeteners, less sugar, less alcohol. Alcohol is very hard on us as we get older, and it's completely normalized. Most of my patient population is having a drink or two a night to unwind, and it dramatically decreases your sleep quality and duration. It puts you on that blood sugar roller coaster so that you're far more likely to be putting on middle weight. your liver's always going to prioritize detoxification. So if it's busy detoxifying from artificial sweeteners and alcohol, you're not going to have its contribution to stable blood sugars or detoxifying your natural estrogen pathways. Another thing that can confound the estrogen piece and give us lots of hot flashes and miserable conditions, constipation. We need to be detoxing. So it's really important that you're managing constipation. Otherwise, you'll end up in an estrogen dominant situation. So there's a whole lot of different things that can go on. So honestly, it's finding somebody. Go to the North American Menopause Society, find a menopause practitioner, and sit down with somebody. Find yourself, it sounds like you have a fantastic functional medicine doc who's on top of the whole health. That's what you really want, is somebody who's working with you from a whole health perspective. Stabilize those blood sugars, more protein than you think you need, more fiber, more healthy fats. Honestly, I'm telling women to shoot for about a gram of protein for every pound of ideal body weight. When we start our days with enough protein, it also increases dopamine, which is our feel-good hormone. It helps with mental health. When we start our days with enough protein, because you think about what you eat for breakfast, right? Usually it's a glass of orange juice and a bagel or like a yogurt parfait or something else. Most of us are not getting nearly enough protein. The protein stabilizes those blood sugars and really does a bang-up job of helping with managing a lot of the symptoms that we get that kind of mimic some of those hormonal sex hormone symptoms. So that's super important as well. Intermittent fasting is really, really important. Delve into and do some work. Dr. Mindy Pelz has an amazing book called Fast Like a Girl, and she specifically looks at fasting in relationship to our cycles and kind of sort of perimenopause, but also that postmenopausal stage. And our bodies just need longer every 24 hours to really hit the reset button and stabilize those blood sugars. So stable blood sugars is a huge piece of it, probably even more so than the sex hormone piece, honestly. But
yeah, I can attest to that because I did a book study in the summer on the Galveston method, and that's basically what she says, So I was like, well, I'm skeptical. But my background is I'm trained as a yoga therapist, and yoga is the practice of experimenting with your life. So I am my own scientist. And I said, okay, well, I'll do the 10-day sugar reduction for myself and just see, does it make a difference? Because the first argument was like, it's going to help with the bloat. It's going to help with your symptoms, and you'll probably sleep better. And I thought that was a really big practice because I don't eat a lot of sugar. It's not like I'm sugar cereal girl or tons of sugar in my coffee or anything like that. But yeah, no, it was true. Made a big difference. A lot of it probably was that blood sugar, just trying to having to overcorrect like that, and making sure that when I do have my breakfast, I'm having a good source of protein every time. And I've taken to having like a nice yogurt with some berries and nuts, and I'm loving it. It's working, honestly. But it's very difficult to think that you're already feeling ill and now you have to make a big change, like looking at what you're eating or how you're eating, and it can be overwhelming. I think that's partially why I brought up the antidepressants, because for that one client, if I had said to her, you're going to change how you eat, she would have just freaked out, and that would have been the end of it. She had to first do medication and then be able to go on.
yes, for sure. And I think it's really important. And I tell people all this all the time. I think we are naturally geared in as a society to look for the easy answer. I always say, if we're lucky enough to get old, it's really hard work. We all need to be told that. It's really hard work to get old. You are now at kind of a crossroads where you get to pick, because it's really hard work to feel lousy every day and to drag your butt out of bed every day and to deal with a host of chronic health conditions and not feeling good and not sleeping and not having energy and continuing to put on weight and, eventually need joint replacements and struggle with chronic health conditions and a myriad of appointments. But it's really hard work to make those diet changes and to exercise. You got to move your body daily. I always say, take the pressure off. It doesn't have to be like some big fitness class where there's strain. I'm like, I love Yoga with Adriene on YouTube. I love Yoga Nidra for meditation with Ali Boothard on YouTube for free, right? It's really important we're taking care of ourselves. Honestly, it looks about moving your body. It looks like resetting that central nervous system and managing stress. Most women, we're so out of whack as far as our cortisol goes, because we have spent decades learning to just disregard every natural instinct we have. It is all about caring for others, doing, going. And it's really hard. But I honestly think one of the best things we can do for ourselves for mental and physical well-being and health is to take a step back and actually start to listen. I always tell women, listen to what you eat and how it makes your body feel. Listen to how you move your body and how it feels. Listen to, who you're around and how you're spending your precious time and energy and how it makes you feel, and honor that, because it is the most important information you can get, right? We're not capable at this stage, between the hormonal shifts and the blood sugar instability, of just continuing to keep that kind of pace. Right. So it really is important to carve out those moments for ourselves and to just really lean into taking care of ourselves and listening to ourselves. It's about that balance piece, right?
Said
Because
that on the radio this morning. I was like, what happens is we have this opportunity. Yeah, we have symptoms and difficulties, but it also kind of makes it crystal clear of some of the things that maybe need to fall away, right? Like the fights with other people about stuff that you don't really care about. Maybe we can just let that part go. Or, joining that class that you've always been thinking about doing, learning pottery or exploring poetry, or, like one of the ladies that I worked with decided that she wanted to actually talk to her women that she regularly would visit with, and they had never talked about menopause, but she decided to bring it up, to broach the subject. And now she has a weekly meeting with these ladies where they discuss their symptoms, and everybody's feeling better.
yes, it is. There's so much benefit and healing benefit to that connection piece. So it's kind of finding your people, whether that looks like finding the right healthcare provider, or, just being able to kind of sort of have a group like this where you can lean into each other and have a safe space to ask questions, or friendships, and just having an open, honest conversation about it. And I see Olympia over here has asked about sleep. Sleep is an elusive beast, honestly. Certainly sleep is disrupted for different reasons. Sometimes we get up a million times a night because our bladder is dysfunctional and we need help with that. Sometimes we're up a million times a night because we're having hot flashes. Sometimes we're up a million times a night because we're stressed about things. Honestly, the stable blood sugars makes a huge difference with sleep. If you're having disrupted sleep because of hot flashes, seeing somebody and seeing what your options are for systemic hormone therapy is very important. If you're magnesium is, by and away, most of us are very shy on magnesium in our culture. We just don't eat enough nuts, frankly, to ever be able to get adequate levels of magnesium. So magnesium is very helpful. What's most readily available for magnesium in most grocery stores and pharmacies, though, is magnesium citrate, and that can really upset your tummy and give you diarrhea. So if you struggle with constipation, great, go hard on the magnesium citrate. If not, it's better to look for magnesium bisglycinate formulation at a health food store, or if you're having lots and lots of anxiety issues, magnesium threonate is very helpful for sleep as well. Decreasing caffeine, our body's ability to tolerate caffeine dramatically declines as we age, and it takes us about a full 24 hours to process that. So, it's not necessarily that your habits have changed, but your body is evolving and changing, and its tolerance for your previous habits may not be the same. So really look at those symptoms: stable blood sugar, decreasing the caffeine, meditation. Because the biggest issue I get is people are full of stress and they wake up because of a cortisol change at 2 or 3 o'clock in the morning, and then they lay there and their wheels just turn. And then they become very anxious and they get heart palpitations, right? So it's really important that we learn how to mitigate that. Exercise, time in nature, leading into something like yoga nidra or mindfulness meditation practice to learn to be able to calm our own central nervous system and shut that piece off.
And then the progesterone, if you do have a prescription, I found it very helpful for helping me to fall asleep. And the mindfulness meditation helped me a lot because I was one of those waking up with cortisol. So I was feeling very anxious, but I hadn't had a bad dream. There's no reason for this to be happening. It's very disorienting. And with the mindfulness meditation, I just had a client say, "Oh, I'm terrible at that, right? I can't sit down and stop thinking." Mindfulness is different because you're not trying to stop your mind from thinking. You're just labeling the thoughts. So you're thinking about dinner for tomorrow. Well, that's the future. You're thinking about what happened yesterday. Well, that's the past. And when you label the thoughts, they kind of land somewhere in your brain. It's like, okay, now I know what to do with that, and I can file that away. I don't really have to keep considering that. And then I do fall back asleep. So it's been like a wonderful exercise in self-discipline. And I don't get up. I try my very hardest not to get up. And if I do get up, I don't turn on any lights. I try and like stay in that zone of like, I'm just going to go right back to sleep and not get stimulated. Because I've had that come up in the group where they're like, we should start a midnight chat, right? So we can all be online chatting on the Facebook group. And I was like, no, because, screen time and bedtime, we don't want to mix those two because they'll, the screens will just wake you back up again.
And just even Google sleep hygiene, right? Just inform yourself. Sleep hygiene's kind of got the host of things that can help with basic sleep. But like I said, if you're waking up with hot flashes and those sorts of things, definitely hormone therapy can be helpful. So I'm sorry, ladies, that was kind of a down and dirty on a whole smattering of perimenopausal and menopausal complaints. So thank you, Jessica, for asking me to come speak. And just remember, each one of you is unique, and just be vocal, advocate for yourselves. And if you haven't found somebody, like I said, check out the North American Menopause Society, find a menopause practitioner. There's lots of complementary and alternative functional medicine docs out there who do a fantastic job of this. It's really important that you're taking charge of your own self, and you don't need to suffer. But remember, there's no magic wand. The hormones are there, they're available. We have terrific options and absolutely a meaningful piece of the puzzle, but not the whole picture. There, it's definitely hard work getting older. So lean into just taking care of you.
Yeah, and that's what I see as well. Like for the women that rely on the prescriptions, they get feeling better, and that's a wonderful thing. But if they've added in making sure that they're watching what they're eating and being a little bit more mindful about their stress, and maybe, taking some things off of the schedule so they're not hectic all the time, they're actually setting themselves up for a really nice long life of health and well-being, because all of these habits are going to prevent these illnesses that would come up, you know what I mean? Because you're taking care of your bones and your muscles, and you're taking care of your mind, and you're having interactions with other people. So you're staying emotionally well, and you're not leaving out any of these elements, right? They all kind of work together in this picture, like you were saying, the puzzle pieces and bringing them all together.
Yeah, absolutely.
Right. So we're just about out of time, and I'm going to thank you profusely from the bottom of my heart for coming, Amanda. I found Amanda through one of my clients who was able to find her, and she is very trustworthy and really literally saved this gal from suffering through a whole summer in discomfort. And, really she just needed some estrogen treatment for her vaginal pain. And now she's feeling, 6 months later, pretty much better, like almost normal. So it is definitely worth the effort of looking and finding someone and pursuing that relationship, right? Wouldn't you say? That's what I say all the time to people. Go back and talk with your doctor again, more like you're establishing a relationship with that person, and see if you can connect with them a little bit more and get a referral maybe to a different gynecologist if you referred to someone that didn't listen to you, or those kind of things, instead of just being like, my doctor's terrible. Because they're a person who became a doctor. They're probably caring.
Oh, for sure. And this, like I said, no human being is an expert in everything, right? So if it's not their area of expertise and they're not comfortable with it, it's lovely to continue a relationship with them for your primary healthcare needs, and
Sure.
then just see, figure out who else you need to add to your team.
Exactly. All right. Well, I'm going to end the meeting here, and then the replay will be available for everybody. So if you missed anything, you can feel free to watch that. It'll be on the cloud. Thank you, Amanda.
Great. Have a great night, everybody.
See you later.